Afternoon, everyone. My name is Ariel Mather, and I'm from the National Center for Equitable Care for Elders. We are pleased to have everyone with us today for the first of two webinars in collaboration with the National LGBT Health Education Center focused on providing care to LGBTQIA+ older adults. So today's topic is sexual health and wellness for LGBTQIA+ older adults. This is the first part. The second part of this two-part series will take place on March 19th from 2 to 3 p.m. Eastern. We hope that you'll be able to join us there as well. Presenting today's session are Dr. Elizabeth Cass, a primary care provider and a hospitalist at Fenway Health and an infectious disease specialist at Beth Israel Deaconess Medical Center. Dr. Jane Fleischman, an expert in sexual health and well-being of older adults, and Paul Seligman, a health promotion peer navigator at Care Resource in Florida. This webinar will last approximately 1 hour, with the presentation lasting about 45 minutes. And after the presentation concludes, we'll have about 10 minutes left for questions and answers. So a little bit about NCECE. We were established in 2017, and we are a training and technical assistance center that provides innovative and culturally competent models of care, interprofessional training and educational resources to healthcare providers providing care to older adults. You can certainly stay connected with us through all those links on the slide after this session. NCECE provides several types of learning opportunities for our health center audience, including learning collaboratives, webinars like this one, and publications focused on the health and well-being of older adults. And like I mentioned, for this webinar, we have partnered with the National LGBT Health Education Center, a program of the Fenway Institute in Boston, Massachusetts. The National LGBT Health Education Center provides educational programs, resources, and consultation to healthcare organizations with the goal of optimizing quality, cost-effective health care for lesbian, gay, bisexual, transgender, queer, intersex, asexual, and all sexual and gender minority people. And certainly if you want more information or to contact the National LGBT Health Education Center, you can use the phone number or the email address on your screen. If you have any technical questions or concerns during this webinar, you can feel free to use the displayed phone number to call WebEx directly, and they can assist you. You can also utilize the Q&A or chat function inside of WebEx to communicate with the host. You can see these functions on the right-hand part of your screen. You'll be able to see a triangle menus and see either Q&A or chat. Feel free to type something in there as well. If you're having any sound issues, make sure your computer speakers are muted to avoid any echoes. If you can't listen through your speakers, you can use the WebEx phone number to call in and listen using your phone. And when the webinar concludes, once you close your browser, an evaluation will automatically open for you to complete. If you complete this evaluation, you'll be able to generate a CME certificate for 1 CME hour as accredited by the American Academy of Family Physicians. You need to complete the evaluation in order to receive the credit, and we, of course, appreciate your feedback on this session today. This activity has been reviewed and is acceptable for up to 1 prescribed credit by the American Academy of Family Physicians. These credits are good for most providers, but please contact the governing body for your profession directly if you have any questions about whether or not you can receive credit for this particular activity. So before I turn it over to our speakers, just wanted to review the learning objectives for today's session. They are to describe misconceptions of sexual activity and stigma in all older adults, including those who are sexual and gender minorities, to recognize the social determinants of health affecting older LGBTQIA+ individuals and how they can impact their care, and finally, to identify clinical strategies for HIV and STI prevention in a primary care setting, and explore screening considerations specific to an older adult population. Please keep these objectives in mind as our presenters discuss this important topic. I would now like to introduce the first of our speakers for today's session, Dr. Elizabeth Cass and Dr. Jane Fleischman. Thank you for joining us today. I'm going to pass over the presenting privileges to you now.
Thank you, Ariel, and thanks so much to all the participants for taking part. I'm Elizabeth Cass. I think I have perhaps the less interesting part of the presentation, and I will try to move through my slides relatively quickly to leave adequate time for Jane and Paul. I want to qualify that introduction by saying that I am not, in fact, an infectious disease specialist, but would describe myself more as an experiential HIV specialist and also an experiential geriatrician, having taken care of older adults now for over 30 years. So I want to start by observing that clinicians and doctors in particular do a notoriously bad job of being open to talking to patients about death. And I would say that we perhaps do an even worse job of talking to patients about sex. Perhaps typical of doctors that I've started by linking death and sex, but I can be forgiven maybe because I started my speaking and my clinical career really in the era of HIV, when in many ways those topics seem to be linked all too often, but the importance of taking a good sexual history was core to what I trained with. I'm going to start with a first case, which I'll read through and then address with some comments. Sorry. I'm having some difficulty moving to the second slide.
You may try just clicking on the slide itself in front of your screen and then try to use the space bar or the next arrow. That's worked for me.
Okay, thank you. So topics that we'll cover, the biopsychosocial aspects of sexuality and aging. Jane will talk about sex positivity and its challenges. Paul will go next, and then we'll have time for discussion at the end. So I'm going to start with case study number 1, with a composite of the sort of people I not infrequently see in my practice. So case study number 1 is an 83-year-old cis woman who comes in to her medical visit with a large number of complicated medical problems. But at the same time that she presents with these medical problems, she comments that she only came out as a lesbian in her 70s. She's been extremely involved with various lesbian community meetings and other social events in her local community, but she has no close family and she's never had an intimate or sexual relationship. She laments that since she came out so late in life and now has so many medical problems, she may never have the chance to have an intimate relationship with a woman. She confesses to you that she has had a significant crush, perhaps her first ever, on a good friend recently, whom she's also identified as her healthcare proxy. That friend, however, has gently let her know that they're not interested in being intimate or sexually involved with your patient. She says to you she's heartbroken to think she might die without ever having a romantic lesbian relationship. So to me, when I see a patient like that, I think about what's the most important response. And I would say to clinicians, the first most important response when somebody brings that up is not to recoil from the discussion and not to shut the conversation down because there are more important medical issues, and not to trivialize the concerns. For this particular patient, where I would find the room is to ask her to tell me a little bit more about what made her bring the question up, to reflect on the remarkable resilience that has gotten to her age and has enabled her to feel comfortable coming out and engaging with the community at this late stage of her life. And think about how she imagines she would like to explore a relationship, and what other things she has been able to do over the last several years since she has identified as a lesbian to explore her own sexuality and give herself sexual pleasure. Case study number 2 is a 68-year-old trans woman. This 68-year-old trans woman comes into the office extremely excited and pleased about the results of her recent breast augmentation. She says she prefers, yes, to take oral estrogen even though she knows the risks, and prefer treatment with transdermal estrogen because despite the lower risks of transdermal estrogen that she's been told about, she feels she gets better feminization with oral estrogen. She notes that at her age, after having survived lung and throat cancer as well as a heart attack, and having waited until her latter 60s to be, quote, the woman I always wanted to be, theoretical health risks of the cardiovascular sort are of lesser importance to her than having her body more consistent with her identity. She announces that she wishes to explore dating men, and cis men, and she wishes to talk about the risks of dating. So with those cases in mind, I just wanted to raise a few issues and then hand the discussion over to Jane. Number 1, I think it's really important when these issues are raised by patients such as these to explore what it is they're hoping for, what their dreams are, and then acknowledge the medical issues and the realities of aging that perhaps complicate those hopes and dreams. It is true that aging presents its own unique challenges. Changes in physiology, the addition of multiple medical problems, perhaps cancer treatment, hormonal blockade for a number of cancers, prostate medications that destroy function for men to a large degree, antidepressants that suppress libido, things for pain which may dull alertness. All of those things play into the mix, but I like to reflect back to aging patients that this is yet another case where people as they age are the own best experts. They've already had to adapt to so much change. And what I like to do when I talk about sex, or I talk about mobility, or I talk about exercise, is to reflect with people on the things that they've had to modify to be able to continue to do things in a way that they do enjoy, perhaps not the way that they did them in their 20s and 30s, but in creative and new ways that permit them to still be able to move forward and do the things that they care about. It is helpful to reflect with people on the negative impact of, in particular, alcohol, methamphetamine, and narcotics, also some of the benzodiazepines, in terms of the dulling of sexual function, but also to acknowledge that for many people, removing anxiety with the use of medication perhaps, decreasing inhibition, the use of marijuana, may be things that are part of people's sexual experience, and if done cautiously and safely, better to open those things for discussion than to have people feel uncomfortable to discuss them. What are people afraid of? People's fears in aging are in many ways very much the same that they are throughout the lifetime in terms of sexuality. It is painful to be rejected in your 20s, and it is painful to be rejected in your 80s. Perhaps all the much more difficult if you have only recently come out in terms of your sexuality. Perhaps all the more difficult if you have a new pair of breasts that you've never gotten to use before, that you've waited your whole life to own. There are concerns, just as there are for people in their teens, their 20s, and their 30s, about knowing how to approach a new sexual partner and how to manage a sexual encounter. There are struggles with body image, as there are throughout the lifetime, but also with changes that do occur with aging. and the difficulties that may be brought on by changes in mobility as people have arthritis and people have pain and people have a knee that doesn't bend or a back that may not perhaps allow the position that it would have allowed 40 years ago. There are also fears about being able to perform sexually, about having things be painful, and overall about opening up to experience that may be unfamiliar. For most people who bring these concerns forward, once again, they are not looking for solutions to those problems, but merely permission to put these concerns on the table, to be heard, and to have perhaps suggestions for resources to be able to explore things in a way that feels comfortable. When the second case person asks about risks, I think it's important always to bring up the topic of risk, safety, and prevention. Paul has a presentation in more detail that talks about the issue of STIs, about sexual activity with late life, just again as in younger life, sexual encounters. But it's important to remember that this implies not just to standard cis male intercourse, but by people of all different sexual behaviors and interests. And this involves really asking people very specifically about what it is they wish to do, how it is they imagine they're going to do it, and what their worries are, and to be able to explore the dimensions of that risk fully. Again, rather than providing reassurance or generalities, it really takes talking about what it is people are hoping and fearing they're going to do. It's important in elder years, just as younger years, to talk about consent and remind people that assumptions are never safe on either part of the equation. It's important to talk about people's comfort level with disclosing their own health concerns, perhaps HIV status, perhaps other sexually transmitted disease status such as HPV or herpes, and above all, to remind people of the importance of honest and open conversation so that people are not broad-sided on either side. In conclusion, for clinicians who are presented with questions to which they don't know the answers, most older people, when they come to physicians, aren't expecting to have simple answers or simple solutions. The most important thing is to make it possible for people to feel safe in asking questions, to feel comfortable in letting them be specific and detailed and not feel judged, and to help them find their way to resources. And to that end, I am going to turn the conversation over to Jane, who has all sorts of resources.
Thanks, Liz. Hi, you all. I'm Dr. Jane Fleischman, and I'm also really thrilled to be here. Thank you so much for all of you coming to be on board with us today. I want to change gears a little bit, and in this next section, I want to talk a little bit about this idea of sex positivity, and we will define it in a minute. But, you know, until about the last 10 years, most of the academic research on older adults was totally focused on problems or on dysfunction, and particularly around sexuality, it was around sexual dysfunction. And what's even more interesting for today's topic is that most of that research, that academic research on LGBTQ older adults, was also focused on difficulties. For instance, a lot of the research that was focusing on gay men was about high-risk behavior. The research on lesbians was on desire dysfunction or low desire. Research on bisexuals, well, unfortunately, was almost invisible, just like that group often feels. And research on transgender older adults was all about how difficult it would be. And so what we wanted to do today is to really turn these tables over a little bit and look at an idea about how you all, as clinical people, can begin to think more about sex positivity with your older LGBTQ clients, and maybe raise some ideas for you about how you can think about it in developing this into your own practice. So we have a third case study for you. Two older women in their 70s recently moved into an assisted living community. One is Black and the other is white. They have two single beds in their one-bedroom apartment. From their medical records, you understand that one of them is trans and the other one is cis. Now, they didn't come out about anything when they moved in, and they've never been explicitly affectionate in front of anyone. The certified nursing assistants assume that they're just friends. But as their healthcare professional, you begin to wonder whether they're a lesbian couple and if they're having sex. So what kinds of assumptions do we often make? And, you know, how can we really begin to think about them in a more complicated way, right? In a more kind of holistic way, and be more respectful and yet non-intrusive. So how do you bring up these issues about gender identity or gender expression or sexual orientation or sexual expression or issues of race or issues of relationship? You know, in many assisted living communities and other senior living residences, they're very small communities, and word gets around and people feel judged, and that's the last thing you want to do in your office, or if you're making house visits to an older adult who might be experiencing some of these different complexities of their lives. One of my colleagues, Joan Price, who's another sexuality educator, said there is no expiration date on sexual health. And what I want you to think about today is whether or not somebody is actually being sexual with someone else or expressing their sexuality with someone else. They might be having solo sex and masturbating. They might be pleasuring themselves. Or they might just be thinking about sex, or they're not thinking about having sex with anyone at all, but they're still in their body, and their body is still a sexual body. And what I like to say is that people are on a sexual journey, and as Liz said before, some of the awkwardness that sometimes happens when people are younger, it's still happening, and people's emotions are just as complicated when they get older as they were when they were younger. So I want to tell you a couple of kind of cool and key things that we know about older adults and sexuality. John DeLamater, who actually just passed away, and one of his colleagues, did a really great meta-analysis around sexuality throughout the lifespan. And we have the link here in our resources later on in the slides. But what they found was that people in their 50s, 60s, 70s, and 80s are still experiencing sexual expression, are still having sex. In my own work with older adults in the classes I teach, anecdotally, people tell me, yep, I'm in my 90s and I'm still having fun. Well, we don't have research on that, but I can tell you that it comes up in my work. And they may, again, not be experiencing sex in the way that they were in the past, but they're considering themselves having sex. The second one I wanted to tell you about is this wonderful article that was published in 2007 by Beverly Whipple, whom some of you might know. She's a very cool, she's still alive, she's very cool sexuality researcher. She's done a lot of work on women's sexual expression and women's orgasm. She's the one who wrote that book on the G-spot, although it wasn't named after Beverly Whipple, it was named after someone else. But anyway, she was the one who wrote that book. She and her colleagues found that regular sexual expression leads to tremendous health benefits, some of which include the risks for cardiovascular disease and the complications of heart disease. Risks for prostate and breast cancer, that sexual expression that leads to an orgasm, and remember, doesn't always, but when it leads to an orgasm, can actually lead to the expression of neurotransmitters and other hormones like oxytocin that can actually act as pain relievers. And the last one that they found, which I'm sure will resonate for some of you, is that it's an overall quality of life enhancer. Dr. Patricia Koch and her colleagues in 2005 looked at body image. And this goes back to what Liz was saying before, that they found a correlation between improved positive notions of your body correlated to positive sexual satisfaction. So keep that in mind, because we know the reverse of that is often true. And an article that I published just last summer with older adults in same-sex relationships in the population that we're focusing on today. By the way, the other 3 articles that I just outlined were mostly about people in what I call mixed sex or heterosexual relationships. But in the study that I did, we found that finding sexual pleasure is really not that simple. It was actually correlated to low internalized homophobia, high resilience, and high relationship satisfaction. And that the relationship satisfaction was correlated to both of those, and that was a predictor for sexual satisfaction. And you can read more about that if you want to go to the article. So let's turn now to sex positivity and body positivity. What do we mean by these terms? I like to say that feeling good about our bodies for all they've been through is all we need to think about in terms of being body positive. Other people might be much more elaborate, but that's all I want you to think about today with your older clients. And that sex positivity is feeling good about our sexual life and our journey, because remember, everybody's journey is different. And for each of the people who come into your office or your clinic, you know that they've had a unique journey. Some of it has been filled with trauma. Some of it has been filled with external feelings of being erased, being invisible, feeling horrible about themselves. And some of them are doing it from internalized sense of that as well. And some of those people are just feeling good. So really keep that in your mind. So why is it so hard for people to feel good about our bodies? And what does that have to do with our sexual lives? And what is it about being an elder in this community that may make these issues even more challenging? And we're going to consider those later. But, you know, folks who are listening, if you're interested in just jotting down some ideas, feel free to put it in the chat box. We'd love to hear your responses to any of these questions. So we promised to talk a little bit about the challenges, and Liz has already gone over many of them. She's already said consent, but I wanted to put consent in there again because it's so important, particularly around older adults who may have some cognitive difficulties. The second is about staff. Staff, I'm talking about staff in a senior living residence or an assisted living or independent living or memory care unit. They may be coming from another country where there's a very different understanding about what it means to be a homosexual and what it means to have sex with someone of the same gender. And so be really conscious of that. Families may, it's funny, it's not really funny, it's funny to me as a sex educator that families often get in the way of sex ed. When the kids are young, often the parents are very opposed to the kids learning about sex. And when the parents are older, the kids are sometimes concerned about, is mom really in love with this person, or are they going to fleece her out of the family farm? And there may be fears. This issue of coming out is a huge one. Some of the older adults that you're going to be working with may not be out, may not feel comfortable coming out, and especially if they move out of their neighborhood into a senior living area, they may feel really nervous about what it's going to mean for them because they want to fit in and they may feel the vibe that it may not be okay. So don't assume that all of your clients want to come out and that you need to be listening for that. And finally, there are a myriad of ethical questions, particularly around what does it mean to be sexual at an older age when you may have some cognitive impairments, or you may be married to someone else, or you may have never been married. You can imagine there are many of those. So what can we as healthcare professionals do to be more body and sex positive in our conversations? And I loved when Liz said, you know, you've just got to be listening more. And I like the term be askable. I don't know if that's really a term, but you know what I'm saying. Be that person who sits with an open heart, and your body language conveys that they can ask you a question, because people are going to be afraid, just as we as professionals often have trouble having that conversation. How do we begin to create a more sex-positive, body-positive environment in a clinical area? How can we promote sexual health and wellness? Well, I've got a few ideas, and I'm not going to read all of them because I want to make sure we have time for questions after Paul's conversation. But the first thing is, just remember, sexual health is a human right. That's primary. I'll just give you a couple others. That aging doesn't necessarily lead to sexual decline. And I like to say that there's no normal in any of these arenas. Normal is the setting on my washer dryer. There is no normal here, and really try to convey that to your clients as well. One of my colleagues talked about this idea of accumulated loss, particularly around body parts, around disease, around divorce, around death. There's so much loss, so really be thoughtful about that. And of course, the last one is, primary care. Put a big star next to that one, which is make no assumptions. And here's some questions you might bring back to your own organization. Are you ready to address LGBTQIA and other older adults' needs? Are you receptive and open to discussing sexuality? Have you ever conducted any training on sexual health around older adults? Do you provide condoms and lube, and are you ready to educate family members? But there's a huge balancing act to all of these. And what kind of balance must your organization establish to address these sexual health needs while also protecting people who may be cognitively impaired? Because you don't want people to have any kind of exploitation at all. And do family members or guardians, conservators, have a right to be informed about an older adult's sexual interests or behaviors? There was a great op-ed in the Times last week around a woman who got the phone call from her father's assisted living community asking her if she would be okay about them providing him with contraception. Those are the kinds of questions that you're going to be asked. And when you're talking about sexual health, here's some just really quick ideas. It can be really scary. I know it is to start these conversations, but again, be askable and be the one who is willing to try to start having the conversation. So accept people's bodies for wherever they are at their age. Be prepared to listen, to really understand, and communicate needs and hopes with regards to their sexual health. And you can say to your clients that they can invite in the possibility of pleasure and what I call emergent joy, and that they can try something new. And that, there's always going to be awkwardness. So remember that humor and patience and loving kindness with yourselves, both for you all as the practitioners and for your clients. So I'm going to leave it at that. I know that we're going to take questions later. I'll let you know that we have a whole bunch of resources on here that are impossible to click, I know. But once you get the handouts, I'm sure you'll be able to find these. And we're going to pass this over to Paul. So thank you so much for your attention.
Thank you so much, Dr. Fleischman and Dr. Kass. I'm just so excited to know that there are doctors like you doing this kind of work. Thank you so much. When we're considering the sexual health of our older adults in a primary care setting, even like mine is a primary care setting. So we are a community-based organization and I'm not having anything happen. There. I want to talk to you a little bit about PrEP and PEP and some prevention strategies for older adults. I'm a very strong believer in this. I'm a huge romantic, and I was a witness to one of the greatest love stories in my family that happened to my grandaunt when she was 78 and met the love of her life at the age of 72. And they were together and created what Kurt Vonnegut used to call a universe of two. So I know that romance and sex and intimacy are all, they continue. They don't end because you're aging. And so we know that we're in the midst of the Human Health Services ending the epidemic plan for America. This conversation is ongoing everywhere, and that there has been a very high spike in the over 55 age group. We're seeing this. I'm also we're very aware that we've got tools in the toolbox at work. The biomedical prevention strategies like treatment and prevention tests and the CDC's big campaign on U equals U, undetectable is untransmittable, is a very important part of it. PrEP and PEP are also very important arms of this strategy to end the epidemic. In our clinic, based on the patients that I've been seeing here just through July 31st, and it changed just a little bit by the end of the year, we have a breakdown of 37% Hispanic, 48% Caucasian, 14% Black, very small percent Asian. It just has to do with the makeup of our city of Miami. And also, even though it's probably more Hispanic, we have to remember that in South America and in Central America, those of us who are Hispanic, think of ourselves as white. So that's why the ethnicity question, the racial question always comes up different. Sexual orientation-wise, we see 85% that are considered MSM, 15% that are considered heterosexual. We have a gender divide. It's growing. We're seeing more females than we were before seeking PrEP and PEP. There's a 2% transgender female. There's an almost negligible amount of transgender male. The great majority are male who come to our clinic. And then there's the age breakdown, and the 3% actually grew to 5% by the end of 2019 on the over 55. And that's what we're going to focus on right now. Now, in terms of the specific risks of infection, older adults who are coming in haven't had a lot of STI testing in a long time. Some of them have been in long-term relationships, they've widowed, they've divorced, and they're trying something new. They're in a new environment, a new world, and they're really unfamiliar with the need for testing, or they have hidden long-term infections that no one had ever tested for. The idea of extra-genital testing is really quite new. Also, older adults may be unfamiliar with online and app-based ways to date and find sexual partners. So for an older adult, using apps and online platforms to find romantic and sexual partners, they may need coaching on how to find and how to be safe. And so we not only have, this has to really be a dialogue. The pitfalls that we find is we have to really understand, why are they here? We have to really question, what is it that they're seeking? Very often when the patient is here in my office talking to me, and I'm the PrEP navigator here, and the PrEP coordinator for the whole program at all our clinics, the provider he had gone to didn't want to do STI testing. His normal primary care physician made assumptions about him and assumed because of his age that he wasn't sexually active. And the joke around the office was that we have a lot of people complaining that they're allergic to pizza. They can't have lactose or they can't have gluten, but the truth is what they have is an ongoing systemic STI in their stomach. So we have to be able to treat them and listen to them and guide them. Why would an older adult come to you for PrEP? Part of it is that they're coming here because they want to talk to a provider who is wants to make sure that they can understand how to prevent an HIV infection. We want to make sure that if they are HIV negative, that they can remain that way. If they have other issues, we don't need to add that one. They may have been refused STI testing of their own. Someone may not think that they have any risks. These are not my slides. Okay. The person may have recently received medical support around sexuality, like their urologist may have given them a prescription for erectile dysfunction. When they asked about PrEP, the doctor said, well, let's make sure that you have safe sex. And the only way to have safe sex is to have an erection. So here's something for ED. Or they went and tried to access PrEP through another provider or a pharmacy, and very often in those environments, they're being sold a vaccine for the flu shot or the one for shingles, but they don't want to be addressed as sexual beings, which is what they still are. And the outcomes that the person has very often come to me for a high-risk encounter. And they were uncomfortable, and after we've been talking for a while and they realize that there's space to speak up because I'm questionable, I can be asked, you realize that this person is here because he had a high-risk encounter with someone and needs PrEP. A very large percentage of the people who are currently on PrEP and over 55 in our clinics first came here because they began with a post-exposure. So there are many reasons that someone comes here, and there are many reasons why there may be provider bias, but we have to be able to get past it. PrEP is a part of a holistic approach to the health of our seniors. And a lot of our seniors, they're not just, as Dr. Cass said, it's even romantic issues. We have to be aware of the fact that they can go out into the world trying to find some joy, trying to live their best lives, and get their heart broken. And then we have to be able to direct them to support services for depression, for the social reality of the fact is that someone who's facing issues of aging, issues of isolation, issues of loneliness, is a very high risk for suicide. So PrEP is a holistic approach or an add-on to it, and we can help to keep them well. Fortunately, it's something that is available. We know that it's very effective, and with almost every kind of insurance, it is available. So manufacturers are providing copay cards and copay assistance or copay foundations. So it's become a very strong part of the conversation in HIV prevention. And using all these tools is how, working together, all of us can get to a point where the babies being born now may be the ones born into a world without AIDS. All right? That's about it. I'll give it back to you.
Thank you so much, Paul. You can, feel free to pass over the presenting privileges to me or to Kay. Great. So thank you so much to all of our panelists for an excellent presentation. We have some time for questions, so we'll let you guys type something into the chat box or to the Q&A. If you can't see it right away, it might be minimized on the right-hand part of your screen. There was one question that came in earlier that I'm going to read now, and any of our panelists can chime in once I read that. So this individual asked, how do we engage clients in a discussion about consent? This individual often tests men who have sex with men of all ages, who through conversation might reveal sexual encounters that might not be completely consensual. Often when this individual has pointed out that substance use, cognitive differences, etc., are variables that can make consent difficult to give or receive, clients seem uncomfortable with the idea that they've experienced sexual trauma or have had sex without consent. So the question ultimately is, how do we provide that kind of safe environment to openly discuss consent without the client feeling stigmatized? Do any of our panelists want to chime in?
I think my first approach, if somebody comes in with that sort of question, I think, or where those things are being raised, is if someone introduces the topic, is to ask them to describe to me a situation that they were in, to give a specific of an experience that they had, perhaps explore how they would want someone else to approach them, and to then use their story to talk through and problem solve with them, maybe role play a little bit, how to make sure that the understanding was adequate on both sides of the picture, and that any unanswered questions were put on the table. A lot of times I have patients express comfort or concern about how to disclose their own HIV status, that they've had some dating, some activity but not receptive activity with somebody, and they worry about when and at what point they should disclose their own HIV positivity, for example, or their own herpes, or their own. And I often point out to them, or I often ask them, so did that other person ask you? And if not, what makes you think that they are not sitting with some of the same questions? And then work with them a little bit in terms of how to approach getting both parties to feel comfortable putting things on the table, maybe going together to get tested if that's an issue of concern.
I had an idea too. This is Jane. You know, Liz, I was thinking the first thing maybe is just to say, thanks for letting me know. You know, like to really give that individual a sense that the question is a really good one, and that you're the right person to be asking, even if you don't have all the answers, but
right.
that you're absolutely interested in their sexual health at that moment, and that asking that question can be one of the scariest things that person has done in a long time. You know what I mean?
Mm-hmm.
And if I can add something in, one of the things I think that's very important to remember is that when there is an age disparity, and there often is right now, that condom negotiation, something they're kind of unwilling to really do. They don't want to do anything that might upset this apple cart. They're very excited to have this young person interested in them. They don't want to scare them off by saying, but we have to use condoms, because we know that young people aren't using condoms. So we have to make sure that they're able to negotiate in a way that they feel like they're being heard, and we have to kind of practice it with them. And absolutely, make room for the conversation, make room for the questions, and acknowledge them and thank them for being able to, participate that way with us.
Right. I would say also that, in the context of the whole risk and protection conversation, it's also often been an issue, and this is really a reminder of the importance of talking about the appropriateness of PrEP potentially for anybody having any kind of risk sex, that in some contexts with some individuals, discussion of condoms may put them at risk for sexual violence. And that needs to be acknowledged or at least explored.
Great, thank you. I know we had a question around PrEP. They've heard a lot of discussion around Truvada versus, forgive me if I'm pronouncing it wrong, Descovy. What's the best practice for having that discussion?
Well, the two drugs are both CDC and FDA approved. The way Descovy was accepted for PrEP October of last year was that it had to demonstrate in the trials that it was not inferior to Truvada. Truvada did very, very well in those studies. And the drugs are good, and they're not going to be the only ways that we have PrEP. PrEP is going to be available in other ways within a very short period of time. So as far as those drugs are concerned, I know that for someone who has the possibility of already having osteopenia or bone density loss, Truvada may not be the right drug for them. Someone who has issues with kidneys to begin with, Truvada may not be the right drug for them. If they have hepatitis B and it's chronic, these are not the right drugs for them at all. They need to be at least, well, they need to at least be followed by someone who's an infectious disease specialist, and they can't just interrupt them, or that could create a flare-up. But the drugs are both very effective, and the price point in between them is almost nothing. Probably by the end of this year, we're going to see a generic form of Truvada on the market, and there will be other products. So the conversations should be had with them, and you guys need to have a navigator in your office that you can send them to, so that they can discuss the issues of how to get them and how to get the drug dispensed.
Correct. I would say at this point in time, the approval of the Descovy is relatively new. I think the expectation is that it, as Paul has said, it's not inferior, and for the most part, the side effects don't tend to be different, although I have to confess as a HIV treater, I have patients who've been long-term on Truvada that I've switched them to Descovy for the reasons Paul alluded to, for concerns about renal risk, kidney risk, or bone loss. And I've had a few individuals swear they felt different on Descovy. So who's to say? I always tell patients I'm not the one taking pills, and sometimes, especially when a drug is newer on the market, 10 years later, we discover there really are differences among things that we didn't recognize when things were in clinical trials and less out in the larger public. In general, as Paul said, if I had people who are already on Truvada and are comfortable with it, and people have no particular risk for bone loss or kidney issues, I don't necessarily switch them. But I would acknowledge in the older population, again, there is a higher likelihood that people have some kidney dysfunction, whether because of diabetes or vascular disease or for a whole host of reasons. So particularly people who are older, I might at least have more of a discussion about the renal risk than in a younger patient without other complicating diseases. And again, older people more at risk for osteoporosis, and anybody who has worked with a lot of menopausal women, bone density starts to decrease quite rapidly in most women after menopause. We think about bone density testing and treating for osteoporosis. So particularly older women, older trans individuals where hormone levels may not be adequate to maintain bone density, those are all populations where it's worth thinking individually whether that person would benefit from a PrEP drug that is less likely to produce bone loss.
The only difference is that right now, Descovy, we don't have any data on women, so anyone who was
right, that is correct. right. Much less trans people with differing hormone levels. So the vast majority of the data is cis men.
No, they have accepted it for trans women. Trans men, no.
Right, but I guess the difference is that we don't know as much with the variety of ways that people opt to have their gender-confirming hormonal therapy done, to know really in terms of that interaction with bone rates. Not that there's a drug interaction, but depending on how much hormone people are taking and by what group, the bone density issues may be greater.
Okay, great. Thank you so much. We are just at 5 minutes until 3 p.m. Eastern, so I'm wanting to keep track of the time. We have one more question, I believe, although if anyone else has anything on their mind, feel free to type it into the chat or the Q&A now while I read this question. Someone wanted to know how they would encourage a participant or a patient to seek help when they report that they already know what to do, but perhaps this person is observing, based on, they're saying maybe appearance, it could be a little bit of a self-bias each time they meet with the participant.
Ariel, we're stumped here. Can you ask the participant to give us a little bit more information?
Yeah, so if it looks like someone named Alicia, if you want to give us a little bit more context in the chat. But the question is basically, how do you encourage a participant to seek help when they report that they already know what to do?
We're having a little difficulty with when the person says they already know what to do about sexual behavior, about protection, about what aspect.
Yeah.
Right. So hopefully we can get a little bit more details in the last minute or two. And if we can't get them now, perhaps we can encourage the participant to follow up with us after the session is complete. Certainly, it's important to clarify sort of what they want a patient to seek help around. I don't see any other questions at the moment. Again, we're almost right at our time. Folks can utilize the chat box or the Q&A to put any last-minute questions in. Kay, have you received any more details from that original question? Okay, so we have no more details yet, but I can follow up after if we receive them. So a few people have asked if this webinar is being recorded. Certainly we will make that available on both the NCECE website as well as the National LGBT Education Center's website. It'll be viewable there for free CME credit. We'll be back in touch with participants with all that information when that's ready to go. So in the meantime, we are going to close out this session. We really encourage you to complete the evaluation for this webinar. It will automatically open when you close out of this session. And we do hope that you'll join us for session number 2 in March, and you'll get more details about that if you haven't seen that already. So this officially concludes today's webinar. Thank you so much to Dr. Cass, Dr. Fleischman, and Mr. Seligman for your time and information, and thank you to you all for participating.
Thank you, Ariel.
Thank you.